Again, good morning, everyone. My name is Emily Dieringer. I'm one of the coalition coordinators for Rethink, Winnebago's Healthy Living Partnership. I am a staff with the Winnebago County Health Department. Rethink serves the entire area of Winnebago County. If you're not familiar, there are 2 health departments in Winnebago County. City of Menasha has their own health department, and then the county health department covers the rest of the jurisdiction. Along with Heidi Keating, we coordinate Rethink. If you're not familiar with Rethink, I think most of you are. Rethink that. There might be a couple puns later on. No, we work with countless volunteers, groups, organization, residents to make health more likely to happen in Winnebago County. So I'm going to give you kind of a hopefully quick little overview on health and equity and all policies, just kind of connecting some of those dots to help you understand kind of the lens that we look through when we're looking at making some good changes for the residents of Winnebago County. So we're going to start at the beginning. What is health? This is the definition from the World Health Organization. It was coined in 1948, and then they looked at it again in the mid-'80s and said, yep, that's still what health is. So health is the state of complete physical, social, and mental well-being, not merely the absence of disease or infirmity. So a lot of times when we think about health, we just think about not being sick. And that's kind of where a lot of times people just stop when they think about what health is or what healthy is. But if we look at a whole picture of health, health is a complete physical, social, and mental well-being. So kind of how can we reach our full health potential, not just not be sick? So that's kind of what we look at when we're looking about health, kind of reaching that whole potential, not just staying out of the hospital. So then if we're talking about health in all policies, that's a collaborative approach to improving health for all people by incorporating health considerations into decision-making across sectors and policy areas. And that's where you come in. You make policies, you make policy changes, you make good changes and sometimes make not so good changes, depending on how that impacts our residents. So health in all policies is kind of a newer phrase or a newer term in our public health world. It's kind of one of those buzzwords, and of course it does have an acronym because we're public health and we're the government. We love acronyms. So this is kind of that new way of thinking for a lot of our staff, and we're trying to help all of our decision makers and our leaders and our residents kind of wrap their brains around health in all policies as a good way of doing things. So some of the key elements of health in all policies, they promote health, equity, and sustainability. So these are things that will last a long time and be better for everyone. It supports multi-sector collaboration. If you know how Rethink operates and what we do, we the health department staff cannot do any of these things alone. It really takes the work of all of our volunteers and our residents saying, hey, we want to make this change because it's going to be better for our community. And that our community is really important. So it benefits multiple partners. There's lots of win-wins. I was recently at a training in Nashville, and one of the speakers was talking about, complex problems require big solutions, and the best solutions are the ones that are a win for multiple people or multiple types of people. So when we find solutions, multiple people win, or multiple groups of people win, so that's great. Engaging stakeholders, that means that the people that are impacted by the issues are part of the solution. And then creating structural or procedural changes. And those are the things that get a little, I'm going to use a Stephanie word, wonky, when it comes to kind of changing that social and cultural fabric of how we operate and how we do things in our community. And these are the types of things that really health in all policies are looking at. So again, we're faced with many complex and interconnected issues. Doug touched on a few of these: chronic illness epidemics, rising healthcare costs, health inequity. These are really big problems, and they're very complex. And one silver bullet isn't going to fix those problems. So a lot of the things that we work on are interconnected and interwoven and really complex, and it makes us want to pull our hair out sometimes because they're so big and they're going to take a really long time. But we know those are the things that are really going to last and really going to make good changes. And no single agency or entity or sector can do it alone. It's not just going to be the public health people. It's not just going to be the city government officials. It's not going to be the healthcare system. It's going to be all of us working together. That's how we're going to make those changes happen. A little bit about health and the economy. In case you weren't familiar, treating diseases costs a lot of money. I don't think that's new news to you, but just a couple things to put it in perspective. Healthcare costs currently in the United States are 18% of the US GDP, which is about $2 trillion, and 75% of those costs are attributed to chronic conditions, and broken down a little bit, cardiovascular disease, so heart disease, is $400 billion, and uncomplicated diabetes and hypertension is $180 billion. In Wisconsin, $1.1 billion is put into Medicaid to treat 6 of the top chronic diseases in Wisconsin. So think about how much money we could save by preventing some of those diseases. And of course, it's not just about the money, it's about the lives too and the quality of those lives. But if you're just a money person, that's a lot of money. And if we put a little bit of that into preventing some of those things, we could save a lot in the long run. Just talking another little buzzword or buzz phrase in public health, policy, systems, and environment, or PSE, is something that we look at a lot, and we use that as our frame of reference for most of the things that we work on. So kind of putting it in a little bit more plain language, I know you all know what policy means. It's the rules and norms that govern how we live, what's right and what's wrong, or what's legal or what's not legal, and then just kind of what's acceptable or what's okay. That's kind of that policy arena. Systems, that's kind of how we operate. So this is the one that gets a little cloudy at times for some folks, that systems are how things work. So one example of a system is we've been working a lot with mental health and mental health care the last few years, and we did a kind of a needs analysis a few years ago, and we thought, our group thought that the issue was access to care, access to mental health services. And when we dove into that issue a little bit deeper, it wasn't necessarily the access that was the problem, it was coordinating getting the access that was the problem. So someone would go into a clinic and say, hey, I have a mental health need, can I get some help here? Oh, sorry, we're booked up until 3 weeks from Thursday. Well, it kind of might be important right now to get care. So what we're working on is trying to change that system to say, if you go into this clinic or this provider and you need access right now, they're connected with all the other providers in the area, and they can book that appointment at that other location for you and say, here you go, you're all set, you have to be here tomorrow, and see you then kind of thing, as opposed to being like, well, we're booked, sorry, see you, bye. So that's a systems change, where it's like how things operate a lot of times is the downfall of getting access to care or not reaching that full health potential. And then environments, we're not necessarily talking about, I always say hippie tree huggers, but then I feel like I offend some people. So environment is more about like our surroundings and the conditions where we live. So an example of that is you might have a park that kids could go play in, but no one goes there because there's not enough lighting and it feels unsafe, or there might not be a safe sidewalk for kids to get there on their own. So those are types of things, environmental changes that we can make that will make it easier for people to make some of those healthy choices. So this is a public health graph chart thing from the county health rankings. And we know from a lot of research what influences or impacts our health and our health outcomes. And a lot of times people will, if you ask just the general public, what influences your health the most people will say health care, access to hospitals and clinics and that kind of thing. And that's really only about 20% of what actually causes health and health outcomes. And a lot of it, that red circled area, is all the things I just talked about, the policy, systems, and environment arena that we can make a difference on influencing. So physical environment, air and water quality, housing and transit, and then social and economic factors, level of education, ability to get good quality jobs, income, family and social support, and community safety. Those influences, or those factors, are 50% of what causes our health. And we can make a difference on that. And of course, up there on the top is health behaviors, and that's about 30%. So it's still partially, the individual's responsibility to say, yes, I want to go take a walk, or yes, I want to eat healthy, or I want to limit the amount of alcohol that I'm intaking. Those are still personal responsibilities, but there's a lot of things that are outside of that individual's responsibility that are influencing or impacting their ability to make some of those individual choices. This is another little chart. And so put another way, some of those outside influencers are some of those roots. And they're adverse conditions and inequities on the dead tree over here. So marketing for tobacco and alcohol, adverse living conditions, income inequities. I know you can't read that, and I can barely read it too. So, but when a person lives in a community that doesn't have a lot going on for it, they don't have the assets and the ability to grow into that big flourishing tree. Kind of going back to the beginning, you might not be sick if you're the tree on the right, but you're not reaching your full health potential like the tree on the right. And the tree on the right is progressive conditions where there's access to recreational facilities, quality schools, access to good health care, quality housing, access to transportation, and good jobs. So those types of things build up and create positive health outcomes where people can really reach their full health potentials. And if you want a really local picture, we actually do have some data that supports this. People in Winnebago County who live in a more walkable environment tend to get more exercise. So the 2 bars on the right was from a question that we asked in fall of 2012 to about 200 respondents in Winnebago County. So residents of Winnebago County were asked, how often do you get physical activity? And there's a whole bunch of questions, and the numbers are equal to METs, which is really like very sciencey, and I'm not really into that. But what that means is people that lived in communities where it was easier to get places by walking got more physical activity. So they were asked all these questions, and then we compared that to where they live, and another question, and it shows that people that live in those walkable communities get more physical activity. And that just means that they maybe walk to the library or walk to the grocery store as opposed to taking their vehicle. And they inherently build in some physical activity without even knowing it, as opposed to like just going to the gym for 30 minutes after work kind of a thing. So our environment influences our ability to be healthy is the short version of what I'm trying to say here. So. Just a couple definitions real quick before we get going with things. A lot of times we talk about health disparities, which is just a disproportionate difference in health between groups of people. But that definition doesn't necessarily address how those disparities happened. They didn't just happen one day. There were things that happened, decisions that were made over years and years and years that created some of those disparities. And that's where we kind of get into those health inequities, where it's not just the difference in population health, but they're systemic and patterned, unfair, unjust, and actionable, which means that we have the ability to change some of those inequities to health equity, which means every person has the ability and the opportunity to achieve their full health potential and well-being. Again, going back to what that definition for health is. Put another way, I'm a big baseball fan, and the graphic on the left means equality. Each kid has a box. Everyone's got a box. Everyone's equally treated. Great. But the little short guy can't see the game. If he's a Cubs fan, I don't care. But if he wants to see the baseball game, we want to make sure that he has the resources he needs to be able to see the game. Well, the really tall kid doesn't need a box. So give that kid no box and give the short kid 2 boxes, and then everybody has equity. They can all see the game. So that's something that is a little bit easier to understand, the difference between equality and equity. And we really want to try to focus on that equity piece. So really focusing on those communities and those populations that have systemically and constantly been left behind. We wanted to pay special attention to those while focusing on the entire population and trying to reach that full health potential for everybody. So your influence on health and equity. Like I said before, there is a point at which decisions are made. And these decisions change those policy systems in the built environment. And some of those decisions impact some people more than other people. So again, going back to the short kid on the 2 boxes. And there are some policies that are bad for health. So today we're going to be talking about 3 examples of health and all policies and kind of the good, bad, and the ugly about some things that could or might or already did happen related to health and policies. So the decisions that you do make and can make change our culture and change the conditions where we live and make it easier for those people to make those individual healthy choices so everyone can reach their full health potential. Paying attention to prevention and treating those bad things before they get too far is something that we really look to do a lot. Another baseball reference, if you constantly throwing out the guy at home, it's so hard to constantly throw the guy out at home. You don't practice that. The easiest out is at first base. So if we can prevent those runners from getting to the end, then we can prevent a lot of things in the Do you have a question? Rethink receives a couple different grants. Currently we have a Drug-Free Communities grant from the federal government, which is $125,000 a year for 5 years. We're in years 6 through 10 of that grant right now, so it's $125,000 a year. We also currently have a grant from the USDA to work on farm-to-school initiatives and getting a food hub built so it's easier for people, institutions to purchase locally grown foods. And that's like $90,000 or something, and that grant ends at the end of this year. And then we have the state tobacco grant that we've had for several years from the State Department of Tobacco Prevention and Control. And that's $70,000 a year or so. So those are our major grants that we have. And then the county does have some levy dollars that are put into Rethink as well. I want to say we operate about 10 staff, which include 3 AmeriCorps members that are serving with Winnebago County for about $325,000 a year. Okay, so we're going to actually go back and watch a little video.